Well, good afternoon, everyone. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland. And welcome to this, the 8th in our QI Connect series for 2018, the 47th since the series began. You'll recall that QI Connect provides an opportunity for colleagues across health, social care and beyond to learn from international experts in the fields of improvement, innovation and integration. So welcome to QI Connect. I'm now going to pass you over to Jennifer, who will tell you a little bit more about the technology we're using this afternoon. Good afternoon, Jennifer.
Good afternoon, Brian, and good afternoon to all of our QI Connectors joining us today. So I just have a couple of quick housekeeping slides to get started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through that in just a moment. If you are experiencing any technical difficulties, such as not being able to hear the presenters today speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A at the end of the session, and we'll also be sharing hyperlinks within the chat function to any resources mentioned by our speaker today, and we'd also be delighted if you could, as our QI Connect community, share resources with us as well. So we did promise that today's session will be fun and interactive. We're keen to find out where you're joining us from today. If you could please select the annotation tool that you see circled in red on the screen there, and then click on the arrow icon. And then select the country you're joining us from using the arrow. And we know that there can sometimes be a slight delay with colleagues joining out with the UK, so we will just bear that in mind and give a few more seconds.
Thanks, Jennifer. It looks as though everyone's joining us from a number of different places. Good afternoon or good morning, Gisela from Canada, from BC, it looks like. And I see in the chat box we've got Alistair Philp joining us from Edinburgh, we've got Becky from Doncaster, and Suzanne from sunny Newcastle, amongst other places. But it's great to see you all populating the map. Thanks very much, Jennifer. Welcome everyone to QI Connect. Well, you'll see from the slide that we're now at 985 organisations who have signed up and used the QI Connect resources. So the connections are live and strong. So as Jennifer mentioned, we're always using competitions and fun to try and get us involved in things. So let's go to the competition. Now you'll see that today we're now looking at 61 countries that join QI Connect, and I'm going to name the flag of the country of today, and the first one to get the flag gets an amazing prize. So if you can put your arrows on again, and the flag of today is Brazil. Okay, that was very close. And Michelle, who do you think was top of the pops there?
Campbell.
Okay, it was so quick.
We'll have to watch the slow motion.
We're going to have to watch the slow motion, so we're going to watch the slow motion. Isn't technology wonderful? Great, listen, well done QI Connectors. We're going to get that name just in a wee moment. Well done everybody else that got on the right flag there. And we'll tell you during the show exactly who won that mug. Thanks very much indeed. Now, it's always amazing to be able to shout out the new organisations who are joining us, and we're now looking at another new 26 organisations that are joining us to bring our numbers up in this episode. From Canada to Australia, New Zealand, across Scotland, the United Kingdom, and elsewhere. So you're all very welcome to QI Connect today. And we're always delighted to put a big shout out to the NHS in Scotland. The whole of the NHS signed up for QI Connect, and it's great to have you all on board. So we're going to move on today and just remind you that we've got now 77 universities, college and higher education organisations that regularly sign up and connect in with QI Connect. We're always delighted to welcome new college and university organisations, and a big shout out to Dundee and Angus College, who are joining us for the first time today. We know that there are groups of students and tutors, lecturers and others that are using the resources both live and recorded for their learning across the QI Connect community. So you are very, very welcome. And we make that easy for you. We have all of the recorded sessions from QI Connect available on Healthcare Improvement Scotland's website to allow you to learn together again and again. And one of the organisations that supports us in this quest is ISQA, the International Society for Quality in Healthcare, and their fellowship programme uses the QI Connect recordings as a resource in their fellowship programme. And the other community that's helping us greatly reach out across the world is the Q community, supported by the Health Foundation and NHS Improvement. We're now seeing Q members getting actively involved in all of the QI Connect sessions, and you're very welcome, and please continue to spread the word. And just a big shout out to our QI Connect team. You've heard from myself and Jennifer, Michelle De Felici, who helps here with registration and running the episodes, and Jessica and Carmen, who work on administration and certification. And Alex Sterling, who's on a well-earned holiday today, is on Twitter Analytics. And just a big shout out to embarrass Jennifer. It's her birthday tomorrow. We're celebrating it today. Happy birthday, Jennifer. And you'll hear from this chap later on. This is Richard Norris, who was the Director of the Scottish Health Council and is currently a visiting fellow with the Academy of Government at University of Edinburgh. We'll hear from Richard a bit later on, but good afternoon, Richard.
Good afternoon.
Now remember, please tweet as you learn at hashtag HISQI Connect. And that brings me on to today's speaker for today. Today's QI Connect speaker is a writer, a broadcaster, a commentator on many health and social care issues. He's been an elected mayor, he's been a local councillor, he's run health and care systems, but he's, I think, mostly known for his insightful critique and commentary on health and social care issues, not just here in the UK, but further afield. And his social media and communications channels reach well over 1/3 of people. So we're absolutely delighted to have Roy Lilley with us today. Good afternoon, Roy.
Good afternoon, Brian, and good afternoon, everyone around the world. Hello.
Great. Roy, we're seeing people in the chat box just saying hello from all over the world, with folk across the UK and across Canada saying hello. So they're just saying hello right back at you. Now we've got we've got a technical issue today. We've cut off QI Connect from London, from Roy's place in London. So Roy and I are going to do a bit of a tag team in terms of moving the slides along today. So Roy, I'm in your hands. Just tell me when to go to the next slide.
Okay, fine, Brian. Thank you for that. So you should all be looking now at a slide that's got my name on it. That's a good place to start. It says Roy Lilley. Is that right, Brian?
That's it. You're on.
Okay, fine. Thank you. Well, listen, good afternoon, Brian. I tell you what, let's get you busy right from the off. Let's have the next slide. And there's a nice picture of London there, because I'm speaking to you from London. I'm in the heart of London. I'm speaking to you from my home on the River Thames in London, and I'm looking out on the Thames, and on the left-hand side, I've got the gleaming image of the Thames Barrier, because it's a beautiful sunny day with a wonderful blue sky. So that's where I am. I know you're all over the world. Thank you all very much for tuning in and joining in, and I look forward to talking to you later on. So let's go to the next slide, Brian. We're talking about quality. This is an interesting topic for me, because although I've spent 40 years in public service, in local government, and in the health service, I've also been in business. I left school when I was 15, and I've been running my own businesses since I was 16, and I'm 73 this year. So I've been in business for a long time, and I've learned that you only really survive in business if you give the customers what they want, if you give patients what they want in the NHS, and if you give taxpayers and community charge payers what they want in local government. There's a whole issue around quality, what it is, what actually is quality, what is it that people want. And Brian, if we could go to the next slide, because I always think quality is not what you think it is. And what I'd like to do, if you go to the next slide, Brian, I'd like to take a moment, if I may, to tell you a true story. Now, some of you I know who've tuned in today will be readers of my daily e-letter that goes out, and I'm going to take a few moments just to read to you from one of my e-letters where I address some of the issues around quality. I'll be picking up on some of these in more detail later, and I haven't got a slide for what I'm going to read you because it's too much to get on the slide, but I'm sure, Brian, we can make it available as a PDF if someone wants it later on. But so let me just read this to you. Quality, what is quality? What is a quality service? Well, for a start, quality is what you do when no one's looking. And how do you achieve it? Well, I think there are 6 steps. Figuring out what you're doing, deciding if you want it, putting things in place to make sure you get it all the time, every time, until you don't want any more. Now, that's pretty simple. That's very basic. But there's a bit more. When I'm driving home late at night, I swing through a small village near where I live in my house in Surrey. It's a place called Bagshot, and I stop off for the world's best fish and chip shop. It's a gourmet experience beyond description for under £7. You get chips and a piece of cod and some peas. It's fantastic. But then again, so is my favourite restaurant in Mayfair, the Caprice. So like beauty, I suspect quality is in the eye of the beholder. A Swatch watch is reliable, fashionable, and costs under £30. A Rolex is £3,000, and they'll both tell you when it's 3 o'clock. We buy stuff that says things about us, and it's important that we don't confuse fashion and status with quality. The basics, well, I think these are the basics. Does it work? Do what it says on the tin. Is it easy to use? Does it work all the time, every time? Does it comply with the necessary regulations? Does it go on working for as long as you need and as long as you think it should? Can it be refreshed, repaired, upgraded? Does it look good, and do you want to be seen with it? And I'll add just one more. Is it seamless and joined up? Now, I wrote this article because I had a most awful experience I've had in all my years around the NHS, and I'm embarrassed by it. It happened to me, and I can get over it, but a lot of people must just give up. And it's a story about patient transport, trying to organise it for a neighbour. Now, normally I'd take this lady to hospital myself, but I was away and I couldn't do it. Now, this dear neighbour of mine is a former teacher. She's very bright. She's in her 80s, but out of the house, she's wheelchair bound and she's not very mobile. Now, for some reason, she knows not why, out of the blue, she received a letter from the hospital asking her to attend on a Saturday morning at 8:30 in the morning for imaging. Now, she had had an operation some time ago, but she feels fine, and no one asked her if the appointment was convenient. It was impossible. She depends on rising services, and they never attend before 9:30. Rescheduling it would be possible, but it would have meant getting up at 6 in the morning to get her ready to get to hospital by 8:30. A phone call, a lot of palaver, got the appointment changed to another Saturday, again in the morning. Getting a scan, follow-up, yes, that's the quality part of NHS provision. On a Saturday for working people, undoubtedly quality, so you don't have to take a day off work. Now next, for this old lady, there was how to get there. The hospital appointment lady doesn't do transport. That's the responsibility of the GP. GP practice says it's nothing to do with them. Ring patient transport at the hospital. Patient transport at the hospital doesn't do outpatient transport. That's somebody else. Call them. So I called them. Now, they ummed and ahed, and they weren't sure that they could do it on a Saturday, and they came back and said, oh, yes, perhaps they could. And then there followed an intrusive interrogation about family support, living allowance, benefits entitlement, NHS number, the condition, the reason for the visit, mobility questions, transfer assistance, that no unregulated stranger should ask on the phone. This was just an administration assistant asking very intrusive questions. And when I challenged that, I was told, well, you see, some people pretend they need transport and they don't. And they just don't want to pay for the parking. Really, I wonder why, when it's £5 an hour at the hospital. And then the cracker question came, how long will you be at the hospital? Now, I don't know. How long will a scan take? Is there a queue? Are they fully staffed at the weekends? So then I was asked, please ring the scan department and ascertain how long the procedure will take so we can arrange pickup for the journey home. The scanner department. Hello, oh no, sorry, we're unable to give you a time as it depends on the mobility of the patient's other pressures and demand. So I rang the transport people back and I lied. I said, it'll take an hour. Now, discounting the time it takes for everyone to answer the phone, the job weariness of the brittleness of the people who are obviously fed up with doing the same repetitive job, the duplicated questions, the fact that I had to lie, and the whole damned horrible, demeaning, clunky, nasty experience, the final straw I was told on the phone, it's not free, you know, the GPs have to pay for this. Actually, they don't. We do. It's our money. It's a quality service to have a scan at the weekend. It's a quality service to be able to get transport if you're a signed up member of the Blue Badge Club. It might be a quality service to commission a dedicated expert transport service, maybe. But you string it all back to back and you break the basic rules. You introduce service interfaces. Where there's a join, there's something for people to trip over. Components may be kind and excellent. The end-to-end experience, horrible. Now, it's not the first time my neighbour has been in this predicament, same palaver. Now, artificial intelligence would have learned my neighbour needs transport, early appointments are no good, she needs a wheelchair, and would calculate the average waiting time it takes to get through scanning on a Saturday. Artificial intelligence would have remembered her NHS number, her address, her status, and made the arrangements about bothering 5 people, 7 phone calls, office and back office overheads, heating, lighting, employment costs, and bits of paper. Bring on the machines. So you can see I wrote that story out of absolute frustration with a service that the components of which were fantastic quality. But you put the bits together and it's the last thing, it's the most hopeless, and all I remember really were the intrusive questions that were being asked by the person on the other end of the phone. Brian, if we could have the next slide, please. So quality is simple, and I'm going to repeat what I've just read to you. Brian, let's go to the next slide. We have to figure out what it is we're doing. We simply then say, is that what we want? Is what we want to do? Now, in management language, they call it audit, audit and reassurance. So, but I prefer to use the English language. Figure out what you're doing. Is it what you want? Put things in place to make sure you get it all the time, every time, until you don't want it anymore. That seems to me to be the absolute fundamental basics of what quality is all about. We make such a huge palaver of it, but it really isn't very much more complicated than that. And Brian, if we could go to the next slide. I often see, I go to conferences and someone will stand on the stage and they'll put a slide up, and in the middle of the slide there'll be a picture of a little old man or a little old lady, and they'll say, I want to tell you about our community bunion service. And they said, we've had the chiropodist there, we've had the podiatrist there, we've had the musculoskeletal people there, we've had the OTs there, we've had the physiotherapist there, we've had a doctor there, we've had a nutritionist there, and we've all decided that we will bring the best we've got to the party and design this wonderful community bunion service. Now that is what I call the donut slide. If you ever see a picture of someone in the middle of a big circle with lots of departments and stuff around it, that's the donut slide. That's the time to get up out of your seat, get on the stage and stab the person making the presentation, because that's just stinking thinking, and we've got to get rid of stinking thinking. What do we do to get rid of stinking thinking? Well, Brian, press the button and we can see start with the patient and work backwards. We do not put patients at the center of all we do. This is lazy thinking. It means that we will always do what we always do, and we will always get what we've got. By starting with the patient and working backwards, it means a whole service redesign. So if we started with my neighbor and worked backwards, we would have asked ourselves the question, is 8:30 in the morning too early for her? If she has rising services, can they cope with that? If she's got mobility issues, have you got a wheelchair? And all of the things that I just read to you, you can see if you start with the patient and you work backwards. And I want to remind you of a story that was a big story in England a few years ago now. It made world headlines, and it's the story of a footballer called Fabrice Muamba. Now, Fabrice Muamba was a young footballer. He was playing in a Premier League division game in London, and in the middle of the game, he had a heart attack. Now, it's pretty unusual for a young, fit athlete to have a heart attack, and it's even more unusual to have a heart attack in front of a stadium full of 70,000 people. Now, the stadium fell silent. There was a paramedic ambulance there. There has to be at our football games. There was a cardiologist, fortunately, in the crowd. The club doctor was there. The paramedics were there. And for 40 minutes, they worked on this footballer to revive him. All told, he died 8 times, but they brought this boy back to life. They put him in an ambulance, and they drove off the pitch to a tumultuous applause at the football ground. And the ambulance drove past 3 hospitals and took Fabrice Muamba, the footballer with a heart attack, took him to a cardiac unit. He didn't go to A&E, to the emergency room. He went to a cardiac unit. Now, why did he go to a cardiac unit? Well, because we discovered in London, even some of the biggest teaching hospitals, they had very poor data on recovery from heart attack. So figure out what it is you're doing. Is it what you want? No, it wasn't what we wanted. We wanted much better outcomes for quality than these hospitals can do. And the reason was high-level resuscitation, high-level cardiac experienced consultants. We didn't have enough of them. They were spread too thin. So we decided to put them all together in one place called a cardiac unit. Now, Fabrice Muamba recovered because we did those 6 things. We figured, we said, is what we're doing what we want? We started with the patient. What will we do for someone who has a heart attack? What's the best thing we could do? Is the best thing to pick him up in an ambulance in 8 minutes, which is our target result? Would it be to get him through A&E in 4 hours, which is our target result? Or would it be to start with the patient and work backwards and realize we have to get highly qualified paramedics at the scene? We have to work backwards from there and take him to the place where the skills are. So we've gone from a service which thought it was a quality service to a service which is a world-class service, and now cardiac units are starting to be established throughout England and Scotland. So we started with the patient and worked backwards, and we've got ourselves into a quality service simply by some pretty fundamental, basic, common sense thinking, figuring out what it is we're doing, asking ourselves if it is what we want to do, and then putting in place what it is we want to do to make sure we get it all the time, every time, until we don't want it anymore. We keep reviewing the outcomes of the cardiac units, and they're terrific. Brian, let's have the next slide, please. Now, the most damaging thing you can do, I think, for quality is to inspect. Now, in England, we have an outfit called the Care Quality Commission, and they are fundamentally an inspectorate. They turn up at your hospital, 200 people, they swarm all over the hospital, they take 3 months to write a report. By the time it's written, it's out of date. Now, the problem with that is it causes all kinds of problems. Now, Brian, if we can have the next slide. This is a BMA survey that came out only yesterday, and I've just managed to sneak it in the slide deck last night. And it says 71% of doctors said the CQC, the care quality inspections, add fear and worry amongst staff, and only 9% said the inspections take system pressures into account. Now, look, inspection was something that we used to do in the 1960s. But even going back to the 60s, one of the most famous doyens, the most wonderful gurus of quality and management, a guy called Edwards Deming, he wrote 14 points of management. And the third point in his 14 points said you cannot rely on inspection as a way of maintaining or improving quality. And he's absolutely right. Because if you inspect, if you turn up and inspect and it's okay, you've wasted your time. If you turn up and inspect and it's good, you've wasted your time. If you turn up and inspect and it's bad, you're too late. So inspection does nothing. We need to look at whole systems. And as I started right at the beginning, I said, quality is what you do when no one is looking. Now, there's quite a famous story here about a hospital in a part of England where they got behind on some of their targets on administering chemotherapy for cancer. We have targets here. They're broken into 2 tranches. They got behind on delivering the chemotherapy for the cancer patients. And 3 people died. Now, we don't know whether the 3 people died because they were very sick and they would have died anyway, or whether they died because they didn't get their chemotherapy. Anyway, you can imagine there was an inquiry, the police were called, the chief executive resigned and the chairman stood down, and the hospital has never really recovered from the shock. Now, here's the important bit of the story. We didn't know that that was going on because some of the middle managers in the hospital had falsified the documents. They'd said they'd administered chemotherapy when we hadn't. Now, that, of course, is a criminal thing to do. But my interest was, why was it they did it? What did we do to turn intelligent, articulate, educated people who come to work with a strong sense of vocation? What did we do? What did we do to turn them into liars? And I tell you what we do. They were expecting to be inspected by the Care Quality Commission. They were terrified of falling short on their inspection, so they lied. These kind of inspections can turn people into liars. Can we have the next slide, please, Brian? So that event got me to the point where I realized that almost everything I've ever done in healthcare management has been wrong. I've thought that it is possible to change people's behavior from on high. I thought it is possible for us to change policy and it would change things happening on the ground. I used to think that I could develop a strategy and have it implemented and it would change things. And of course, it's only really in recent years, and I'm coming, I suppose, now to the end of my career. I've learned this too late, but I want you to learn it early in your career, that you can't change anything from the top. You can only change things from the ground up. You have to engage people from the ground up. If you want to change services, if you want to improve services, if you want to figure out what's going on, you can't do it from the boardroom. You can't do it behind the manager's desk. What you can do is you can get out from behind the desk and do what Tom Peters teaches us in his fantastic book, In Pursuit of Excellence. That's, put it on your reading list, Tom Peters, In Pursuit of Excellence. Tom Peters teaches us about management by walking about, getting out and talking to people. If you want to change things, if things aren't going right, then you go to the place where they're not going right and you say to people, look, we all know things aren't going right here. What is it we need to do together to fix it? And the most important words there are we and together. And can we go to the next slide, please, Brian? And the other issue, the other thing I've found is show people what good looks like, and they'll always get on and do it better. Now, the story I told you about the hospital and the cancer outcomes, it was big news here. And on the day the news broke, I was on a stage talking to an audience about quality, and I said to them what I just said to you. What is it we do to turn intelligent, articulate people, highly educated, with a strong sense of vocation, what do we do to turn them into liars? Wouldn't it be better if we had a system where if people had a quality problem, they could ring up somewhere and say, listen, we got a problem with our quality on cancer. Has anybody else got the same problem? And somebody would spin a Rolodex somewhere and say, yeah, there are 3 hospitals that have had the same problem, and we'll put you in touch with them and you can share that best practice. And I said rather in a light-hearted way, really. I said, wouldn't it be terrific if we had something called the Academy of Fabulous Stuff that we could ring up and say, who's doing fabulous stuff on this or that? And when I got off the stage, somebody came up to me and they said, you know, Roy, that's a really good idea. Why don't you do it? I said, what? He said, the Academy of Fabulous Stuff, why don't you do it? I said, do you think so? Do you think I should do it? And he said, yeah, I'm absolutely sure. So, Brian, can we have the next slide, please? I looked around at the management lexicon and I thought about it, and I'd learned years ago about the power of positive deviance. Now, positive deviance is really interesting. And can we have the next slide, Brian, please? Because I'm going to give you a definition, and I'll just read it through with you as you can see it now on the screen. Positive deviance is based on the observation that in every community there are certain individuals or groups whose uncommon behaviors and strategies enable them to find better solutions to problems than their peers, while having access to the same resources and facing similar or worse challenges. Now, you know, putting that in plain English, as I said, I try and do plain English wherever I can. You know, if everybody's in the same boat, somebody will be able to find a way of rowing better. So in our NHS in England, we've had flatline funding for almost 10 years. There are all kinds of delivery problems. But there are some hospitals, there are some individuals who are able, because of their uncommon behaviors and strategies, to find better solutions to problems than their peers. And so much of this, of course, revolves around the quality experience of the outcome and the experience of the patient. And, you know, I put it quite simply, when you get home from you've been at work all day, you slump on the sofa and you sit down and you use the best invention known to man, the screw-top bottle of wine, so you don't have to find a corkscrew anymore, and you pour yourself a nice big glass of white wine, you think, phew, I've had a really hard day today, and it's been really good. Well, my question to you is, how do you know? How do you know there isn't somewhere down the road someone doing exactly the same job as you, better? And how do we know there isn't somewhere down the road who wish they could do their job as good as you, if only they knew? So thinking about the power of positive deviance, thinking about the need to drive up quality and the outcomes in our NHS and looking after people better. Brian, the next slide, please. I started something called the Academy of Fabulous Stuff. And Brian, if we could have the next slide, you can find it on the web. You just Google the Academy of Fabulous Stuff, www.FAB-ulous, and you'll find it. And I started it with a very simple ambition to make a repository of people who wanted to share best practice. Now, the thing about the Academy is this. It's not academic. It's not in theory. It's people who've had a problem, sorted that problem out, and said, we've fixed this quality problem, we've fixed this operational problem, we found a way to do this faster, better, safer, cheaper, and we're going to share it with you. We're not going to say it works where you are. We're going to say it works for us. Please take the seed corn of our ideas and plant it in your organization and see what grows. And so now, 4 years on, the Academy of Fabulous Stuff has grown to an internationally recognized organization. I was in Canada and Ontario just recently, and in Australia, talking about it where it's going to be set up and running there. It's very simple. We say to people, if you've got something that works, share it. So they write 500 words. They're allowed to introduce 5 pictures and as many links to hyperlinks as they like, and they share best practice. Now, we've had well over 3 million hits on the website. The dwell time is 7 minutes, which is extraordinary. We get 2,000 hits a day, and we have hundreds and hundreds of people sharing best practice. And I think, you know, in my own way, me and the team, the fabulous team at the Academy of Fabulous Stuff, have contributed more to the quality of outcomes in our NHS than inspection ever will. Inspection terrifies people. What we're saying to people is, if you've got a problem, hey, come and share it. Now, Brian, the next slide, please. So that's my story from London. So what is my message on quality? What is my message from London? My message from London is simply this. Quality isn't complicated. Quality is having a good look and deciding if what you're doing is good enough. If it is, put things in place to make sure you do it all the time, every time, until you want to change it. If it isn't good enough, think about the footballer, Fabrice Muamba. He had his life saved because somebody said, are our cardiac services good enough? And we said no. And we put things in place to change that. And it was very difficult to persuade some big London teaching hospitals that they weren't going to do cardiac services anymore. But it takes brave managers to do that. If you want brave changes, you have to have brave managers. Leadership, you know, is about a very simple thing. It's about good leaders give good people the time and space to do great things. Quality is about giving good people the time and space to do great things, about starting with the patient and working backwards. Quality is asking those questions. The simple questions that I started out with you when I started this afternoon, figuring out what it is, what you're doing, deciding if it's what you want, putting things in place to make sure you get it all the time, every time, until you don't want it anymore. Quality is an inclusive thing. Quality, you won't get quality if you frighten people into believing they've got to change what they do. Quality is making people feel like they're in charge. The quality is a journey that's never ending, and quality is the most important thing we will ever do. Quality is about outcomes. Quality is about safety. Quality is about enjoying the process of going from sickness to wellness, and it's a wonderful journey, and it's a goosebump thing to be involved with, and I've really enjoyed my journey, and I've enjoyed your company this afternoon, and thank you for listening.
Thank you very much, Roy. That was brilliant, and the chat box has been buzzing throughout, so we'll come to the chat box questions just in a moment. But let's bring Richard Norris back in. Good afternoon again, Richard.
Good afternoon. Thank you, Roy, for that talk. That was really interesting. Really enjoyed it. I was interested in your definition of quality. You said let's not complicate this, and you said let's use ordinary language. And I thought that was a great approach. I suppose my question is really around what role do you think the public have in that definition of quality? In other words, when you ask the question, is it what you want, how wide or broad is that definition of you in that sentence? And I suppose a slight corollary of that is, what do we do if different people want different things?
Well, that's the kind of the $64,000 question. So let's start with the first part of your question first. The first part is engagement with patients. You know, as well as having been in and around the public sector and public life for nearly 40 years, I've run businesses for all that time. And I would never, ever start a business, and I would never, ever run a business without asking my customers what they thought of the business. Because, you know, you would be crazy to try and sell something nobody wanted to buy because it was no good. So for me, I've kind of grown up engaging with the customers. What is it they want? I mean, I've recently had the great opportunity to take over the running of the Institute of Health Managers. And the first thing we started when we said, well, what do we do first? I said, well, it's obvious. We ask the members what it is they want. And, you know, what I find, what I've found a lot in dealing with the public is that the public aren't overly ambitious. I mean, if you think about my neighbour and her trip to hospital, what she would have liked, I mean, we could put up with all the rest of it, but she just couldn't get up early in the morning. So if I'd said to my neighbour, what will be a quality service for you for imaging, she'd say, well, please, can I have it after 11 o'clock? You know, the rest of it she'll put up with. So if you ask the public, I think the public are much more sensible and much more easy to engage with. And, you know, there's a great way of doing it. We don't do enough of them. They're called citizens' juries, and I'm a big fan of citizens' juries, which is a topic, I think, for a whole new webinar, but they're worth having a look at. When you get contradictory answers from the public, well, I think you have to do the greatest good for the greatest number. But I think you also have to be clear to the people whose ambitions you can't meet. I think you have to say to them, look, you know, I know you want this. We have to put a rationale behind the use of resources. We can't do what you want yet, but it's on our to-do list and we'll get to it. And the important thing then is make sure that you do.
Thanks, Roy, and I agree with you. I agree about the citizens' juries, and I think there is huge potential there. Interesting enough, I think there are good examples around the world of citizens' juries, but it's very difficult finding a policy connect. In other words, it's very difficult finding examples of where citizens' juries have looked at questions and where you can find policy impact, and I think that's an important area to look at.
Well, I would just cite one example. We have the National Institute for Care and Excellence, NICE as we call it in England, and you've got a similar organisation in Scotland, and I'm sure NICE is replicated around the world. But NICE did start doing citizens' juries over the very difficult issue of whether or not we should be making certain drugs available on the NHS, given their cost. Now, they stopped doing citizens' juries mainly because of issues of cost and organisation. But what was interesting was the outcomes from the citizens' juries, when the public had the full facts, were always very sensible. I mean, there's no difference. We are the public, aren't we? You know, we come to work and we put our, managing the NHS hat on, and we think we're different people. We're not really. We're consumers of the NHS. So, the big question, of course, perhaps I should mention it, the one question to ask is this service good enough for my mum? Is this service good enough for my daughter, my kids? If it's good enough for your own family, then it's probably good enough.
Thank you very much for that, Roy. And as you say, there's probably a whole debate to be had and an episode to have on citizens' juries. But I see from the chat box that Stephen Fenning, our Clinical Leadership Fellow who works with us here in Healthcare Improvement Scotland and also with Scotland's Chief Medical Officer, Catherine Calderwood, is citing the citizens' jury that's underway at the moment, looking at realistic medicine. Roy, I'm sure you've heard of realistic medicine in Scotland in terms of Catherine Calderwood's attempt to get healthcare workers, doctors and others, of course, to consider shared decision making.
Yes, and that is it is so valuable. I mean, what we generally get wrong is we say, oh, we're going to consult the staff or we're going to consult the public. We don't give the public or the staff the full picture. We don't take the time to make sure they understand all the nuances of the data or where it's taking us. And it's often better if it's delivered from a neutral standpoint as well. But as I say, I suppose I'm repeating myself really, but my experience over the years is that customers are quite sensible. They understand they can't have gold bars for brass money. And the public understand as well that our services don't have limited funding. So if you treat the public sensibly, give them the full picture, you'll get a very sensible answer, I think.
And Karen Braithwaite, who's a practice pharmacist in Murray here in Scotland, agrees with you. She says they have to be brave, however, to admit to the public that a service has imperfections and needs to improve and wants help to do so.
Yeah, I think that's true. And as a manager, there are two tensions that arise out of this. You get the managing up tension and the bullying down. Now, workplace bullying is again a story for another webinar another day. But just quickly, the tension that arises out of that, the way I see it is if you ask people to do something from on high, and I refer you back to the slide where I said, for almost all my time I've been in the NHS, I've got it wrong, because I used to believe you could do something from on high. I've been involved in 7 or 8 major changes and planning the strategy around it in the NHS. They've not really changed anything at all. It's the little things that really change things for the patient experience. But if you try and change things from the top down, you simply cannot do it. You have to engage with people, and you have to talk to people, and you have to show people why. And I don't see there's anything wrong with saying, saying, look, we have so much money this year from the Treasury. Now, if you don't think it's enough, go and talk to your Member of Parliament. It's nothing to do with us. We've got what we've got, and we're trying to manage what we've got the best way we can. Now, we think the best way we can do it is this. or that. And then, of course, you will get people who put pressure on you with lobbying and all the other things, saying, well, what about us and what about this? But I think if you show people that the whole picture and say, look, you have to see how you fit into the whole picture, and you have to see the difficult decisions, the moral and ethical decisions that we have to make, how we try and do the greatest good for the greatest number, and engage people in that way in a very, very open way. It's very rare that you'll come unstuck.
Well, again, that's echoed in some comments from Tony Anderson from NHS Education Scotland, and also Alison Milne from OD Consult, when they're asking, how do we get politicians to be brave enough to support service redesign when their constituents don't want it or don't understand it?
Well, that's really good. When I ran a hospital, I used to have a lunch once a month in my office. Actually, it was a private lunch, and I would invite the local MP, one or two key executives from the organisation, and perhaps a handful of local councillors. And we would take our jackets off, we'd roll up our sleeves, and we'd be honest with each other. And politicians are under all kinds of pressures, aren't they? Because they have to think about the whips, they have to think about how they're voting, and sometimes they have to take a public stance. But it's very difficult for a politician to make a public statement about something that you've briefed them on, because if they start in public saying to the local newspaper, well, I think this hospital is making really stupid decisions because of this, that, and the other, and you can say to the newspaper, do you know what? Last Friday, that MP sat opposite me in my office eating a sandwich, and I told him exactly the reason for it. They'll only go to the newspapers once. So maintain good press relations, be open with the press, and I think openness with the press is an ally. A lot of people run away from the press. They shouldn't. I think it's okay to say, look, we've got so much resource, we can do so much with it. After that, go and ask the members of Parliament.
Thanks, Roy. And there's a comment in the chat box from Emma Asham sharing an example which allowed the local voice to become very powerful in some changes in Pulteney House and Bayview Care Home. Listen, let's move to one of the other areas that you kind of flagged up about top-down or bottom-up. And Andrew Ruck, who's the managing partner at Swansa European Economic Interest Group, and he's asking, and it's a question about national things. So how can we reconcile a once for Scotland approach, for instance, applied to digital transformation in the NHS, with a bottom-up approach that you're advocating?
Well, sometimes you can't, I suppose is the answer to that. I mean, we've got ourselves into a mess in England because all the hospitals here, they're called hospital trusts, some are called foundation trusts, and they are semi-autonomous, and so they can do pretty much what they want to do. And we've had a disastrous legacy, really, over all things IT and digital. And what has happened is we've sort of recreated an electronic Tower of Babel, where we've got hospitals who've bought different systems. We've got some systems that won't talk to others, and now we're getting around to understanding the word interoperability. Interoperability is a new buzzword. The difficulty is that what we really should do, what I think we should do as someone who's run a business, is we should sit down with all of the trusts and say, right, what do we want our IT systems to do? Let's figure out what good looks like. And then go and buy, we've got 157 hospitals here, go and buy 157 boxes of it, plug it in, and let's get it working by Tuesday. But we haven't done that, and we're suffering from the legacy of that now. We have a new Secretary of State, Matt Hancock, who comes from an IT background. In fact, he was the Minister for Digital before he got this job, and he's actually written and designed an app himself, so he is very net savvy. So our new buzzword here is interoperability. I think there does come a time when you do have to make particularly perhaps in procurement decisions, you have to say, okay, we're going to make this decision. Now, that isn't to say that you don't involve people in that decision. You know, what does a hospital patient administration system look like, a PAS system? How does it connect in to secondary care? I mean, in England, I don't know what it's like in Scotland, but in England, we've got a number of proprietary systems that are used by GPs that have no capacity to connect to the hospital. And indeed, some of the manufacturers are quite obdurate about allowing that capacity to connect in to the hospital without, you know, a lot more money and a whole load of palaver. And they're really holding, I think they're holding the public to ransom over this. It's pretty clear, isn't it, that healthcare without access to digital, without access to records, is like flying blind. And no one is going to get in a plane with a blind pilot. We're flying blind. Without data, we're flying blind. Without data, it's dangerous. Without data, there is no quality. And so I think perhaps we're in a new era now of understanding the importance of that. Artificial intelligence, of course, is so interesting as well, how we can build off algorithms, and we can only do that by syndicating some of the patient experiences. So I think it's a really good question, and my answer, I think, is that when it comes to something like IT, it's pretty clear we have to be, in inverted commas, top down. That doesn't mean to say we're bullying down. What we're doing is we're saying, okay, let's ask everybody what it is we should be doing. Let's distill that into something that's deliverable. Let's go out for tender and find out who can deliver it, and we'll do it all together. Because if we don't, we'll have 157 hospitals that can't talk to each other.
Thanks for that, Roy. And we're going to send some links through to the previous talks on QI Connect from David Bates from Harvard, and also from Bob Wachter from the US, in terms of some of the digital thoughts that they had also. Thanks very much for that, Roy. Now, just flicking back to one of the other areas that you highlighted, which was around systems of quality. And again, Emma Asham, who's a service change advisor with the Scottish Health Council, that's part of Healthcare Improvement Scotland, my organisation. Emma is asking, what do you think about having inspection and improvement being carried out in the same body? Is this an issue or are there advantages? There seems to be an ongoing debate around that.
Yeah, well, I wouldn't have inspection at all. I wouldn't do that. I mean, I think if a chief executive of a hospital has got to rely on inspection to find out what's wrong in his hospital, you've got the wrong chief executive. So I just think it's about improving the quality of leadership and improving and educating our leaders. So I wouldn't do inspection. So for me, having the two functions in one organisation wouldn't arise. However, I don't want to duck the question, so I will answer the question. And the answer is, it's obvious to me they should be separate organisations, because, you know, change is a very difficult thing to do. People can often be resistant to change. People love change if they think they're in charge. And that's the only thing you need to know about change. People love change if they think they're in charge. And that means involving people. How hard is it to make people think they're in charge, carry them on the journey? And the other thing to remember about change, I always think, is respect the past and take the best of it into the future. In other words, don't throw the baby out with the bathwater. So respect the past, because there will be good things that have been done in the past that you can take into the future, but don't throw the baby out with the bathwater.
Thanks for that, Roy. And clearly in Healthcare Improvement Scotland, we do have both scrutiny or assurance, quality assurance and improvement in the same organisation that's split up in other countries. I think the difference that we see here in Scotland is that we're differentiating between internal checking that everybody needs to do to know whether things are working or not, and the external quality assurance and what that adds. Your description of inspection and its impact on individuals and its impact on systems is one that we are certainly trying to avoid here in Scotland. And there's good commentaries from you and from others, from the Nuffield Trust, from the King's Fund and others, around how that is working.
Yes, it has to be a collegiate experience. You have to get yourself into a situation where an organisation knows it's not doing very well in a particular area and can go somewhere and say, can you please help me? I know we're not doing very well with this. Now, that's an analysis of data. I mean, maybe organizations submit their data to a central depository, and the data is compared, because you can be working, as I said to you earlier, you know, you get home from work, flop on the sofa and think, I've done a great day's work. Well, how do you know? It's the same with a hospital, an organization. You think, you know, well, we're doing a pretty good job in this hospital. Well, how do you know? Until you compare yourself with the best, you won't know. And, you know, comparing yourself with what's happening in Scotland may not be big enough. Maybe you should be comparing yourself with what's happening in the United Kingdom. Perhaps we ought to be comparing ourselves with what's happening in Europe. How it was all something to learn how people go about their businesses. So I think really I think we're kind of getting close to the nirvana that I see, and that is getting the data out of the organizations, finding out where there are dips, where there's a gap, where something isn't around the mean, and then say, you know, there's obviously an issue here, can we help you? And then the experts come in and they have a look at what's going on. And we've done it in England. We had terrible problems in A&E, and we still do because they're chock-a-block. But on a great outfit called ESIS, the Emergency Services something or other, whatever it is, unit, I can't remember what the acronym stands for now, but these are A&E experts that go into other A&Es and they talk peer-to-peer on what the problems are and how things are could be reorganized or changed. And they've had great results because people know they're speaking to people who haven't come to belittle them, haven't come to publish a league table, haven't come to make them look stupid on the front page of the newspaper. They've come to share knowledge and experience, and that's why the Academy of Fabulous Stuff, I think, has a place in healthcare.
Thanks very much for that, Roy. That's a nice positioning of the internal checking that's necessary. We've got Alison Milne, an OD consultant at OD Consult, who's asking this core question, which has come up in a number of comments, which is, what are your suggestions for reducing fear in the system, the fear that you described in your examples and the fear that have been described by many working in the service?
Yeah, absolutely. Well, I mean, my knee-jerk reaction is we've got to find a better way of improving quality than turning up with a busload of people with clipboards and frightening everybody to death. What happens is you get, you know, government. Most targets are political. The MPs get a post bag full of complaints from people saying I've waited too long in A&E. It culminates in the Department of whatever health it is says, well, we're going to stop people waiting in A&E and we're going to say everybody's got to be seen in A&E in 4 hours. Now, our 4-hour target has no clinical meaning at all. It was a political target. It turned into a clinical thing because we had to improve clinical things to make it happen. But and what happened, of course, with that is, you know, the politicians told the bosses of the hospital told middle management. Middle management said to everybody else, go away and deliver this, don't bring me back bad news. And when the bosses said to middle management, what's happening, middle management said, oh, everything's okay, boss. So you manage up and you bully down. So that's where all the corrosive behavior starts. If I was running a hospital now, I would get everybody together and I'd say, look, I don't think that CQC add very much to any of this. And I know it's a nuisance and a palaver, but it's something we've got to get through, and we'll get through it together. The important thing is we support each other. The important things, we highlight the good things that we're doing. And if there's anything to learn, well, we'll learn it. But this is not going to upset us because we're good at what we do. We come to work with the intention of delivering a great job. And this is about leadership, you know. Leaders, I said, didn't I? Leaders create the time and space for good people to do great things. Leaders always hire people who are better than them. Leaders hire people who are better than them. And leaders are visible, have a vision, and share it often.
Roy, thank you very much indeed. That's a good place to leave. I'll just leave with one final comment from the chat box. Kath Cooney, who is the Chief Executive at Linn Consult in Sweden, has said that, has referenced Brené Brown's QI Connect talk last month, where she talked about vulnerability, but also the importance of psychological safety, and that's not driven by fear. And that resonates very closely with your comments around positive deviance. And also that Alice MacLeod, who's a senior nurse at NSS, was singing the praises of the sharing of good practice. And it's great to see the Academy leading the way in that. So listen, we're very grateful to you, Roy. We've come to the very top of the hour. We will be moving on. We've got the questions. Just to say that the next speaker in this year's QI Connect is Fiona Godley. Fiona is the Editor-in-Chief at the British Medical Journal. She's a commentator on healthcare. She's an established researcher. She's recognised throughout the world for taking on causes. And we're looking forward to hearing from Fiona on the 31st of October. And we will remind everyone again that the BMJ IHI conference is coming to Scotland's #1 city, that's Glasgow, for those of you that didn't know, in 2019. So we're encouraging you all to come here, and we'll share what we're learning and doing here with patients and the service to improve quality in Scotland. Look forward to seeing you all then. QI Connect will continue. Great lineup for this year. We'll see you on the 31st of October. Remember to follow us on HIS QI Connect. And it just remains for me to thank Roy again and Richard and the rest of the team. Have a great rest of the day. Thank you very much.